My name is Philippe Lucas, and I'm a PhD student in the Social Dimensions of Health program, a graduate researcher with the Centre for Addictions Research in British Columbia, and founder of the Vancouver Island Compassion Society, one of Canada's oldest non-profit medical cannabis dispensaries. Additionally, I'm one of about 50,000 Canadians with federal authorization to use cannabis as a medicine. Today I'm going to be presenting the results of a recent study titled Cannabis as a Substitute for Alcohol and Other Drugs, a dispensary-based survey of substitution effect in Canadian medical cannabis patients. My co-researchers on this project are Amanda Ryman, Mitch Earlywine, and 5 community-based dispensary representatives, Stephanie McGowan, Megan Olson, Dory Dempster, Brian Thomas, and Michael Coward. So what exactly is substitution effect? In a nutshell, substitution effect is an economic theory that suggests that variations in the availability of one product may affect the use of another. And some examples of deliberate drug substitution include the prescription use of methadone as a substitute to heroin and the use of the patch or e-cigs instead of nicotine. So however, not all psychoactive substitution is the result of a deliberate decision made on an individual basis. At the population level, it's often the unintended result of public policy shifts or other social changes such as cost, legal status, or availability. For example, when Australia wanted to reduce drinking and driving rates, they increased the tax rate on high alcohol beverages and lowered it on low alcohol beverages, leading to a subsequent reduction in alcohol-related automobile accidents. And so cannabis substitution, whether for medical or recreational use, can be the result of A, economic shifts affecting end-user costs, such as health insurers covering the cost of medical use. B, shifts in policy that affect availability, such as state programs that have legalized dispensaries. C, psychoactive pharmaceutical substitution, like using cannabis instead of alcohol or opiates. Or D, legal shifts that affect criminal risk and associated repercussions, such as the recent legalization initiatives in Washington and Colorado. The scientific framework for cannabis substitution effect is actually long-standing and fairly well established. An examination of hospital drug episodes in 13 U.S. states that decriminalized the recreational use of cannabis in 1970s, Karen Modell found that users shifted from using hard drugs to marijuana after its legal risks were reduced. Findings from Australia's 2001 National Drug Strategy Household Survey specifically identify substitution effect, indicating that 56.6% of heroin users substituted cannabis when heroin was unavailable. The survey also found that 31.8% of people who use pharmaceutical analgesics for medical purposes turned to cannabis when painkillers weren't available. To date, international drug prohibition has made clinical trials on cannabis as a treatment for problematic substance use nearly impossible. However, a number of studies on both humans and animals suggest that the cannabinoid system plays a role in dependence and addiction to both licit and illicit substances. For example, research shows that nicotine cravings can be modulated by the endocannabinoid system, and recent studies suggest that cannabinoid receptors interrupt signaling in the opioid receptor system, and affecting both cravings and opiates and withdrawal severity as well. Additionally, a study of the New York State Psychiatric Institute on people with cocaine dependence with comorbid attention deficit hyperactivity disorder found that cannabis users were more successful than other patients in abstaining from cocaine use. An earlier study by Labigolini Jr. et al. Also noted this effect on people with a dependence on crack cocaine, reporting that 68% of the 25 subjects who self-medicated with cannabis in order to reduce cravings were able to give up crack altogether. Substitution amongst medical cannabis patients was also documented in a few studies by my colleague Amanda Ryman. Most recently in a 2009 study of 350 medical cannabis patients in California. In that study, 40% of participants reported having used cannabis as a substitute for alcohol, 26% as a substitute for illicit drugs, and 66% as a substitute for prescription drugs. The most common reasons for substitution were again cited as less adverse side effects, better symptom management with cannabis. Additionally, in 2011, an analysis of 1,655 potential medical cannabis patients seeking recommendations from a clinic in California revealed that 13.2% reported using cannabis as a substitute for alcohol and 50.8% reported using cannabis as a substitute for prescription drugs. exploratory research suggests that cannabis use does not interfere with formal substance abuse treatment. Data from the California Outcomes Measurement System compared treatment outcomes between authorized medical cannabis users and non-cannabis users who were admitted to a public substance abuse program in California. And although the sample was small, the medical cannabis patient group fared better or equal than non-cannabis users in important outcome categories such as treatment completion, criminal justice involvement, and medical concerns. More recently, Scavone et al. Examined the impact of cannabis use during stabilization on methadone maintenance treatment in 91 patients with a dependence on opiates, finding that cannabis users spent less on opiates overall, and that the subjective rating of opiate withdrawal decreased in patients using cannabis during methadone maintenance stabilization, which I think is a really fascinating finding that I hope we can reproduce here in Canada as well. The authors conclude that their findings may point to novel interventions to be employed during treatment for opiate dependence that specifically target cannabinoid-opiate system interactions. The study I'm presenting here today is a cross-sectional survey of the subjective impact of medical cannabis on the use of both licit and illicit substances as self-reported by 404 medical cannabis patients recruited from 4 dispensaries in British Columbia, Canada. In order to conduct this research, I teamed with and trained staff representatives from 4 medical cannabis dispensaries located in British Columbia to gather background and demographic data of patient participants, as well as information on past and present cannabis, alcohol, and substance use. A 44-question survey, similar in scope to a questionnaire designed by Amanda Ryman while at Berkeley Alcohol Research Group, was used to anonymously gather data on the self-reported impact of medical cannabis on the use of other substances, included but not limited to restrictions and patterns of problematic substance use. Participating dispensaries are the British Columbia Compassion Club Society, Canada's oldest and largest dispensary that currently serves about 9,000 members, the Vancouver Island Compassion Society, which was founded in 1999 and serves over 2,000 patients, the Green Cross Society of British Columbia, which was founded in 2005 and serves 1,500 patients, and the Vancouver Dispensary Society, which was founded in 2008 and serves over 4,000 patients in 2 locations. While the first 3 dispensaries are located in Metro Vancouver, with a population of over 2 million, the Vancouver Island Compassion Society is located in the Greater Victoria area, with a population of about 200. Each dispensary sought to recruit 100 volunteer participants, and the total survey sample for this study was 404 medical cannabis patients between the ages of 17 and 71, registered with at least one of the 4 participating BC-based dispensaries. The sample was 67.1% male, 71.6% Caucasian, 12.5% First Nations Aboriginal, with a total mean age of 44, which I think really flies in the face of people who think that medical cannabis is only being used by youth or young males, which has been a characteristic that's been identified in California. Income levels were significantly lower than the Canadian average, with 58.2% reporting they had incomes of less than $20,000 per year, 24% report earnings between $20,000 and $39,000 and $999, and 17.4% report earning $40,000 or more. This compares with 63% of the Canadian population that report earning $20,000 and over. When asked about their primary method of ingestion, 48.8% reported using joints or blunts, 10.4% reported pipe use, almost 8% used oral ingestion, such as baked goods, oils, or tinctures, and 6.2% used water pipes or bongs. Although only 4.7% report using a vaporizer as their primary method of ingestion, this is more than twice the rate of vaporizer use reported by Earlywine and Smucker Barnwell in 2007, who found they did a general survey of cannabis users, and that might suggest that this sample, which is a medical user group, has a higher commitment to potentially healthier ingestion techniques compared to cannabis users in the general population. 88% of the patients reported daily use, with over 30% reporting that they use cannabis more than 4 times per day. 24% reported using 10 grams or more per week. 52% used between 6 and 9 grams per week, and 23% used less than that. In regards to substance use other than cannabis, 44% reported current alcohol use, 49% smoke tobacco, and nearly 20% cite that they used a drug other than cannabis or prescription drugs in the past 30 days, with the most common drugs reported being crack cocaine, heroin, methamphetamine, and MDMA, and 26.8% report a personal history with substance use. Additionally, over 52% report they have been raised in an alcoholic or abusive family, which is an interesting finding, and 19.6% state they have been treated for alcohol dependence, with over 5% participating in the 12-step program and 3.5% in another type of alcohol recovery program. Over 75% of respondents report that they substitute cannabis for another substance. 41% cite they use cannabis as a substitute for alcohol, 36% use cannabis as a substitute for illicit substances, and 67.8% use cannabis as a substitute for prescription drugs. The three main reasons cited for cannabis-related substitution in the survey are less withdrawal, fewer side effects, and better symptom management, suggesting that many patients may have already identified cannabis as an effective and potentially safer adjunct or alternative to their prescription drug regime. Before I discuss the potential impacts of these findings, I'd also like to share the unpublished results of a substitution effect study from 628 medical cannabis patients from the Cannabis Access for Medical Purposes survey, otherwise known as CAMPS. The CAMPS questionnaire is a 414-question cross-sectional survey that was made available to Canadian medical cannabis patients online and by hard copy in 2011 and 2012 in order to gather information on patient demographics, medical conditions and symptoms, patterns of medical cannabis use, cannabis substitution, and obstacles to safe access to medical cannabis. Responses were then analyzed in SPSS to identify statistically significant correlations with other patient characteristics. With over 628 responses, CAMPS is the largest polling of medical cannabis patients in Canada to date. And this data has already resulted in 2 publications, and I recently completed a third paper specifically on cannabis substitution effect, and this is a preliminary look at some of the findings. Overall, 86.6% of CAMPS participants reported using cannabis for at least one other, as a substitute for at least one other substance. 80% of patients reported they used cannabis as a substitute for prescription drugs, 51% used cannabis as a substitute for alcohol, and 32.6% used it as a substitute for illicit substances. The main reasons cited include better symptom management, less adverse side effects, and patients who listed a greater number of symptoms were more likely to report cannabis substitution, and interestingly enough, patients below 30 years old were far more likely to substitute cannabis for prescription drugs, alcohol, and illicit substances than those 50 and over. And I speculate that this could be due to a number of factors. That one, maybe younger patients have a higher rate of alcohol and other substance use in general, and therefore they'd be more likely to substitute cannabis for it. And 2, maybe younger patients may be more familiar with recent anecdotal and scientific evidence about cannabis substitution effect, and therefore may be more likely to engage in deliberate substitution. And lastly, older patients may be more fixed in their substance use routines, and therefore may be less likely to substitute cannabis for other substances. In light of the alarming rise in pharmaceutical opiate addiction and associated increase in opiate-related morbidity and mortality, a growing body of research suggests that cannabis may prove to be a safer substitute with a lower potential for dependence for those treating chronic pain. Additionally, since the intravenous use of opiates, crack and cocaine, crystal meth, can all lead to the transmission of serious chronic conditions like HIV/AIDS and Hep C, evidence suggesting that cannabis might be an effective substitute for these highly addictive substances could be part of a public health-centered harm reduction strategy aimed at reducing disease transmission and overdoses from injection drug use. Since alcohol has by far has a far greater social, health, and financial impact on individuals and communities than all illicit substances combined, public policies informed by the growing evidence that cannabis might reduce or even treat alcohol dependence could have a significant impact on overall rates of alcoholism, and consequently on alcohol-related automobile accidents, violence, and property crime. As we've heard here today, a growing body of evidence suggests that cannabis, one thought of as a gateway drug to addiction, may ultimately prove to be an exit to problematic substance use for some individuals. Given the credible biological, social, and psychological mechanisms behind these findings and other similar studies, Further research is justified on both economic and ethical grounds. And perhaps clinical trials with those who've had poor outcomes with conventional psychological or pharmacological addiction therapies may be a good starting point. For my part, my PhD research proposes to establish Canada's first medical cannabis open patient cohort in order to track patient patterns of use, examine strain symptom correlations, and study cannabis substitution effect longitudinally. In the coming years, cannabis or cannabinoid-based treatments for dependence and policy shifts allowing adult, safe, legal access to cannabis may ultimately increase the potential positive personal and public health impacts of cannabis substitution effect and subsequently decrease the suffering and social costs of problematic substance use and of our failed and expensive war on drugs. I'd like to end by thanking the many cannabis patients who've shared their thoughts and experience with us, with my co-researchers as well. I'd like to thank CARBC for supporting this research. I'd like to thank UVic and IdeaFest for this opportunity, and all of you for your time, interest, and attention. I look forward to your questions and having a bit of a discussion on cannabis use and cannabis substitution effect. Thanks a lot.